can you just chop it off, please? And they say it in a slightly flippant way, but I know there's an element of, actually, I just can't deal with my limb anymore.
I think one of the best therapies for CRPS is...
Would you put Botox on the stellate ganglion? She was completely pain-free, but not only pain-free, but she had that pain that was gone from her face. You know that you walk in and you see a patient and you can see the pain is not there. You haven't even said hello to them. Interventional approach for acute CRPS.
The neck has a lot of sensitive structures in there.
Yes, big blood vessels. What options do patients have? Because a lot of these patients will have chronic CRPS.
The one therapy that I think is a bit underutilized in general is...
Welcome to the Pain Diaries Podcast, everyone. My name is Christelis. I'm your host. I'm joined by my trusted friend and colleague, Lewinsohn. Today, we're going to be discussing interventional approach, an evidence-based interventional approach for complex regional pain syndrome. What it looks like, when to use it, when not to use it, and how to essentially stack things in your favor. If you've got anyone with CRPS in your life, or if you've got CRPS, then this is for you. Stick with us until the end, because at the end we're going to talk about something quite controversial, quite aggressive in terms of an interventional approach, and that is amputation. There have been some recent studies on amputations, so we want to cover this for you and for your benefit as well. Today we're going to be discussing interventional approach, an evidence-based interventional approach for complex regional pain syndrome. What it looks like, when to use it, when not to use it, and how to essentially stack things in your favor. If you've got anyone with CRPS in your life, or if you've got CRPS, then this is for you. Stick with us until the end, because at the end we're going to talk about something quite controversial, quite aggressive in terms of an interventional approach, and that is amputation. There have been some recent studies on amputations, so we want to cover this for you and for your benefit as well. Bradley, welcome back. How are you? What's happening?
Not much. We've just been working away. It's coming to the close of the year over here in Melbourne, so everything gets a bit busy before Christmas time. How have you been?
Yeah, good. I'm ready to go home. So we're trying things a little differently today, aren't we? We're doing it at the end of the day, so we're not as rushed. So let's dive in. CRPS, we see a lot of it in this clinic. This clinic has been around for more than 10 years. We've seen 23,000 patients, a lot of them CRPS, a lot from Australia, Victoria, Melbourne, Australia-wide, and some even international. So we know a thing or two about managing CRPS, particularly the diagnosis. So what I wanted to do today is I wanted to talk about a treatment approach for CRPS, but just an algorithmic interventional treatment approach. What things do you need to do while you're having a treatment approach or you're having an intervention for CRPS? Because I want you to just remind our viewers what not to forget about.
Well, look, we discussed this in our last podcast when we were talking about CRPS and its diagnosis, but every pain management or pain intervention, in my opinion, needs to be combined in something that we call a biopsychosocial approach, which means absolutely, focus on the biological component, but you need to focus on patients' mental health and make sure that's being addressed, because the mental health is always a second side of the pain experience for patients. And then you need to work on the physiotherapy, physical approach as well. So we'll come on to, with CRPS, some of the stuff that patients need to be doing is keeping the CRPS limb active, keeping it engaged in exercise, and doing greater movement imagery.
Okay, so physically fit and strong, mentally fit and strong, never forget about that. And if you're making progress, good, and that's the use of medications as well. But if not, then interventions are absolutely, in my opinion, in your opinion, based on some evidence, appropriate.
Absolutely.
Good. In terms of CRPS and interventions, there are three factors to the condition, to the disease. One is a pain problem. Two is an autoimmune problem, an autonomic problem. And then there's the immune problem as well. So pain, autonomic, and immune. And those are the three avenues that you've got to focus on. And that's why sometimes things fail, because people elsewhere might focus on one and not all three. But you've got to really think about all three. So let's talk about acute CRPS. Now, we'll give you some links where you can find some more information on our videos on CRPS in general. As I said, just interventions. acute CRPS. What do you do in terms of an interventional approach for acute CRPS?
So for acute CRPS, and just to highlight, acute CRPS is usually considered between 3 to 6 months. There is some good evidence out there for doing something called sympathetic blockade, where we place a needle around the sympathetic plexus and block the sympathetic inflow into the limb to reduce the pain symptoms. And sometimes we even combine that with some of the somatic innervation, i.e. the feeling the nerves that usually control the feeling in the hand of the limb.
Okay. Which is more common, hand or foot, just generally?
Generally, it's foot.
Okay.
A lot more foot and ankle injuries than hand injuries.
Okay.
But CRPS obviously can occur anywhere in the body.
I got that. So let's focus on the leg then. So if you're going to do a lumbar sympathetic block, you do that at the L2 level, because that's where the lumbar sympathetic plexus is. You would also do some nerve root injections or DRG injections as well. So the sympathetic block, as you said, is for the autonomic part of the pain, and the DRG injection is for the pain part of the pain, correct?
That's correct.
When would you do that in somebody?
Ideally, what we do is go back to the evidence, and there's some good systematic reviews looking at early sympathetic blockade and a series of them to reduce down some of the pain, and then tying back into what we said earlier, engage back with the mental health and with the imagery and the physiotherapy and the desensitization. And so what it ideally tries to do is bring down some of the pain symptoms and give the patient a window of opportunity to desensitize the nervous system.
That's the key, isn't it? A window of opportunity, because nothing lasts for a long time. Some things we do generally can last for months, if not years, but you want that window of opportunity. So what you've got to have ready to go or going is the physiotherapy or the hand therapy or the occupational therapy, so the physical side of things.
And the psychologist as well in the background. So you need to have that whole team ready to work with.
And so how long would you expect a sympathetic block to work for?
It varies.
Yeah.
I'd like to say a good sympathetic blockade may last up to 4 weeks.
Okay.
But some patients can only have a number of days. And that might be with the first one. And then occasionally you can do, say, a series of 3 sympathetic blockades just to get a bit more desensitization of the nervous system. And like you said, those 3 components, the sympathetic outflow, the autoimmune component, and just bring it down to a certain degree.
I found that it lasts for about a month, like you said, and generally here at this clinic, we do them every month for a series of 3. And in some people, I get the feeling that it's a little additive, if there is such a thing. It kind of one block builds on the next block, which builds on the next block.
And what you're hoping to do is just reverse that neuromodeling, the plasticity part of the brain.
Yeah.
That's generating some of these abnormal pain pathways in CRPS.
When in the process of CRPS would you do it? Because we're talking about acute CRPS, and I've certainly found that if you do these sympathetic blocks when the acute phase is gone and it's now a chronic phase, so a different type of CRPS, they may not work, correct?
Correct, yeah.
So the earlier you do them for the acute CRPS, the better. If the block works and the patient does well and then they kind of revert back down again, how else would you approach sympathetic blocks to provide a longer lasting control?
Well, interesting you say that. I think we've got a few modalities that we could look at to try and get some of that longer lasting control.
Yeah.
And there's some good evidence out there for the use of botulinum toxin around the sympathetic plexus. And what that involves is, instead of using the local anesthetic and steroid component that we normally use to block the nerves, we put Botox down. And the nice thing about Botox is it blocks acetylcholine nerves, and the preganglionic, i.e. before it gets to the sympathetic plexus, those nerves are acetylcholine releasing nerves.
Are you using doctor talk again?
I am. I just need to rein it back. Sorry.
Tell me. What? So what happens?
So the Botox, instead of getting a 4 week, can get you somewhere between 2 to 3 months.
Yeah.
So you're looking 8 to 12 weeks worth of desensitization, giving you a bit more space with that window.
I've had some people where it's lasted even longer than months, multiples of months. And I'll put a link on this for our viewer. There was a paper that guided us in doing this a couple of years ago, sympathetic block with Botox for complex regional pain syndrome. And their study showed that it lasted for up to more than 200 days of pain reduction, which is, I can't do the maths right now in my head, but that's a long time. That is many months, as opposed to just a local anesthetic injection, which lasted for, I think, 50 days, so a couple of months really, which is a massive window of opportunity, isn't it? And you can always repeat it again, can't you?
Yeah, and when it's running out, put a bit more Botox in. There's no contraindications per se in how many Botox injections you can have.
Yeah.
Obviously, there's risks involved in doing these Botox injections because we're blocking these nerves, but it can also block some nerves to muscles.
Okay.
And it can cause a little bit of weakness in some patients. The nice thing with Botox is even if it does cause that weakness, the weakness resolves far sooner than the actual pain relief
and
resolves.
The effects, yeah, I've noticed that as well. So Botox is another option. Depending on where you have it done or where you are in the world, Botox can be an expensive chemical, but it's just one of those things that we've got to weigh up. If you're going to get 6 months of pain reduction and functional gains, then it's a balance between pro and con.
I don't know about you, Nick, but the only issue I sometimes have with the Botox is finding that right dose for the patient.
Correct.
There's a number of studies out there, and the dosing range is quite variable, and obviously some of the different Botoxes are variable in their effects as well.
Yeah.
But getting the right dose for that patient can be a bit tricky.
What do you use?
I tend to use just standard botulinum toxin A, which is the first Botox that's been discovered. And I usually, depending where I'm putting the Botox, if it's for the lumbar sympathetic plexus, I'll use 50 units, and I might use 25 units if I was trying to target, say, the arm.
We'll come to the arm. So I use 7,500 units depending on the contrast spread. So you put the needles in, you make sure they're safe. You inject something called contrast, which helps you understand where the solution is flowing. And we'll have some pictures on the screen for you. And if it flows in a nice, comfortable location where the spread is not all over the place, then you can be a little more proactive, a little more aggressive with the dose that you give. But you're right, anything from 50 to whatever, 100 units. So we've done sympathetic plexus blocks for the lower legs associated with a nerve root injection for the pain. So it's basically 2 procedures in one. So for example, if you've got pain in the knee, you would do an L3 and an L4 nerve root injection at the same time. If you've got pain in the foot, you would do an L4 or L5 or S1 nerve, depending on where it is. But classically, pain in the top of the foot or the big toe is an L5 nerve, so that correlates with the L5 nerve, so you treat the appropriate nerve. So we've done the lower leg. Let's move on to the upper arm. So what sympathetic plexus do you focus on for arm CRPS or hand CRPS?
The one that is commonly used is the stellate ganglion.
Okay.
And so that's a bunch of nerve fibers that coalesce in the neck and then go out to feed almost the right upper quadrant, so it can help with face, shoulder, all the way down into the arm. And so it has a lot of projections down the body.
So if somebody's got acute hand CRPS with those autonomic features, so red, puffy, swollen, hypersensitive, you do a stellate ganglion injection. What nerve root injection would you do with the stellate injection?
It depends on whereabouts in the hand it is.
You tell me.
So if it's involving the thumb, I'd target C6. If it was the little finger, I'd do C7, C8.
Gotcha. So you've got to think about the pain. You've got to understand the pain, where the pain is, and you correlate your treatment related to the pain area. Would you put Botox on the stellate ganglion?
Absolutely. I'll put some Botox on the stellate ganglion, but the patient has to be prepped that there can be issues with Botox on the stellate ganglion, such as a bit of hoarseness of the voice, a bit of swallowing difficulties. But again, these will resolve a lot sooner than the weakness or the hoarseness of the voice.
Yeah, I mean, if you generally, as you do practice the same way I do, really, is you know your patient before you do something to them. You've got to have an element of rapport and an element of trust, and you would talk through potential side effects. I certainly know that a long time ago, I used to do stellate ganglion injections using fluoroscopy, X-ray, and nowadays we're very good at using ultrasound to actually see the plexus and to put a needle right on the plexus. You can actually see the needle go onto the plexus and inject it under live ultrasound vision, which I believe is a much better approach because you can actually get your endpoint. And I've certainly gotten a lot better at that. And when I use ultrasound, the outcomes are far better. So if somebody uses X-ray to do stellate ganglion injection, it may not be as good as ultrasound. Would you agree with that?
Oh, absolutely. Not only that, the neck has a lot of sensitive structures in there.
Yes, big blood vessels, trachea, thyroid, and a whole bunch of other things.
And we like to think that we're all built with the same roadmap. But when you actually put that ultrasound probe on, you can see that some people have got arteries where there's not supposed to be arteries, or blood vessels where there's not supposed to be blood vessels, or the plexus is actually a bit more anterior, a bit more posterior.
Yeah.
And so using those old landmark guided techniques of the fluoroscopy onto a bone is nowhere near as accurate, I think, as using ultrasound in the neck.
So to our audience, if you're getting this done, make sure that you have an appropriately trained pain specialist doing it. Make sure you ask them the right questions, which we might come to in a little while. Make sure you understand what you're getting into, and make sure they're doing it in the right technique. If they're going to use fluoroscopy, X-rays, probably not as going to get a good a result as using ultrasound guidance, correct?
And look, I think fluoroscopy is a great tool. I use it all the time. And in some instances, fluoroscopy is better. In other instances, like the stellate, absolutely, ultrasound, I think you can get more bang for your buck.
Yeah. So acute CRPS, we're talking about injections on the autonomic system, the sympathetic plexus, and the nerve roots for the pain. If these treatments are not long-lasting enough, or you don't have access to Botox, or it's not enough, what other things could you do in terms of providing longer-lasting neural stability?
The one treatment that I really like, because I find it works very well with neuropathic pain, obviously in carefully selected patients, is pulse radiofrequency neurotomies. And looking at the evidence base for pulse radiofrequency isn't as good as, say, the blockers or the Botox, and that's mainly because of the way that it's funded. However, the results that you can get from the pulse radiofrequency is fantastic. The safety profile of pulse radiofrequency is also really good because we're not doing damage to the body. We're not heating a nerve and destroying it. We're simply stunning it with some high voltage electricity to get a long-lasting result.
Correct. And we've done some other talks on pulsed radiofrequency versus radiofrequency ablation, but I really, as you do, really like using pulsed RF for nerve roots because it helps with the pain processing part of it. I also like using it on the sympathetic plexus. It's sometimes a little tricky to get it working well on the sympathetic plexus because the plexus is a big structure, it's a big area. So ways that you might, things that you might do to more likely make the pulsed RF work. I suppose what I'm trying to say is how do you get the dose up for the electrical dose so you get a better response with pulsed radiofrequency?
Some of the techniques we use is what settings we use on our pulse radiofrequency treatment. And again, because the evidence is poor, you'll see different markers, but there's a lot of evidence now for actually using higher voltage with a narrow band frequency. And well, these are all just very specific settings, but we're getting better at learning what settings work better to get you that longer lasting approach.
Correct.
And I know that some of my patients now, I'm seeing 6 or 12 months after a pulse radiofrequency treatment, and it's giving them that long window of opportunity.
Yeah. And again, I think you can expect to get about 6 at least or 12 months of pain control from one of these treatments. And if it works, and if you're getting this big window of opportunity, what's to stop you from getting it done in a year's time again, rather than taking opioids 3 times a day? Have a pulsed radiofrequency once every year or so. For me, it's a no-brainer.
The side effects with the pulse radiofrequency, especially when we use the high energy, sometimes it does cause a little bit of a pain flare afterwards. But most of my patients who experience that, the pain flare will only be for around a week or 2 after a pulse radiofrequency. And the long-lasting results, patients are very happy with that. And they use a bit of short-term analgesia to get over that pain flare, and then are off the medications.
So if you were going to tell our audience, if they want to seek out this kind of an injection with whoever's looking after them, what things should they ask their pain specialist? Or is there anything they should ask their pain specialist about having a pulsed radiofrequency? I don't know. I mean, what would you say? Well, I suppose if you were taking your wife in to see a pain specialist and she had CRPS, and you're not going to treat your wife, of course, because that's not a good thing. But what would you ask whoever they're seeing?
Good question.
Why is she not being seen by somebody at this clinic? Sorry.
That would be the first question. Why hasn't she seen Nick yet?
So she's seeing somebody else. What are you going to ask them? Or what should our viewers ask about PRF?
Well, you have to be familiar with the therapy. So
do you do it?
What kind of treatment results do you expect to get from the therapy?
Okay. What do you expect? I suppose you could ask if you've been trained in interventions as well, because some are and some aren't, and some are good, and so I suppose some are not, like anything in this world. Do you need to be a pain registered fellowship trained pain specialist?
No, you don't. I don't believe I don't believe it's a requirement to give the therapy, but okay. I would want somebody who's been trained in this therapy. And no offense to any of my colleagues, but not many specialties are actually trained in this therapy and how to use it.
Right. And that's why it fails, like anything. And that's why in this practice, we've been open for 10 years. We only do pain management. We are not dabblers. We're not solo practitioners. This is all we do. We live and breathe this 24 hours a day. So we're good at it. And it's important that you are treated in an area of excellence or a center of excellence where they get very good at things because they do them, they talk about them, they learn about them. We have little MDTs amongst ourselves so that we're constantly learning and we're constantly getting better at what we do. Okay, so we've done a little bit of the acute CRPS. Let's move on to chronic CRPS. And again, you've got to make the right diagnosis for chronic CRPS, but for our audience, is essentially pain that has been there for a long time. It's not this acute, red, hot, swollen, puffy CRPS. It becomes cold and mottled, and sometimes there's contractures as well. The treatments we use for acute, the injections, don't work in the chronic phase. What options do patients have? Because a lot of these patients will have chronic CRPS.
And chronic CRPS is a lot more tricky to treat because a lot of those neural pathways have now been embedded within the nervous system to a large degree. And with that, like you're saying, a lot of behaviors avoid using the limb. And then the sensitivity, conversely, because you're having all these avoidant behaviors, increases. And so what you need to do is try and turn that neural sensitivity down to a large degree. So the nerve blockers, aren't going to achieve that longer lasting relief. So we have to look at more advanced therapies.
I've had a thought, and if somebody's got chronic CRPS, is it possible for them to get an acute flare of their CRPS?
Oh, absolutely.
So therefore, you've got this chronic CRPS and you have this little period of time where you've got acute CRPS again. So you get red, you get hot, you get swollen. So you kind of patients drift into and out of CRPS-ness, if you want to call it that. So I suppose if they've got this acute flare, then you can do all the acute stuff, which we talked about, but presumably not. So this is just chronic, dreadful, debilitating, devastating CRPS.
That's been with them and is just at this background level.
Correct.
And even background level of CRPS will do that kind of up and down.
Yeah.
They may have some better days followed by worse days.
Okay.
And what we have to think about is, what therapies can we employ? Even in chronic CRPS, I still think pulse radiofrequency would have a role to play.
I would absolutely concur with you. So pulsed RF. Do you need to do any nerve blocks first?
It depends on the patient. The common teaching is that you do a single level nerve block before you then go on to do pulsed radiofrequency treatment. That's in an ideal world. And the other thing we have to bear in mind is time for the patient, cost for the patient.
Yeah.
And in my opinion, if the pulse radiofrequency is going to work, just go ahead and do it.
It's going to work. It's either going to work or not.
Yeah.
So you either just get on and do it or not. There's no point in doing a block.
The only advantage to doing a block is that you'd avoid a little bit of that pain flare. And most patients, as long as they're educated that this can cause a bit of a pain flare and we may not get the result that you're looking for, I'd say just go ahead and do the pulse radiofrequency.
So pulsed RF of the nerve roots, yes, for chronic CRPS. Pulsed RF of the lumbar or sympathetic plexus or stellate plexus for CRPS, yes.
Absolutely.
Okay.
Yeah. Even though patients don't have that florid sympathetic response, there's still, I believe, a lot of sympathetic mediated pain in CRPS, whether you've got that hot swollen limb or not. Chronic CRPS.
So chronic CRPS, pulsed radiofrequency treatment absolutely should be done because you get that window of opportunity.
And not only the drawbacks of the therapy are so minimal, it's worth a try.
Sure, understand. And if it works, you've got an opportunity and you can always repeat it again should the pain return or flare at a point in the future. All right, we're on chronic CRPS, long-standing CRPS. What other options are available?
There's always a role for trying the Botox therapy around the sympathetic plexus. Even in chronic CRPS, the evidence for it in chronic CRPS is less than acute CRPS. But absolutely, it's worth a trial. So
lack of evidence doesn't mean lack of therapy. You've just got to be careful, cautious, and apply things appropriately.
And for that right patient, it can be a very good holding pattern for them. Like you said, if you get that long-lasting response of 200 days with a Botox therapy, a little bit of weakness.
It's 200 days.
200 days. Yeah. Patients are over the moon with that.
So let's take that little controversial step forward and discuss other forms of advanced therapy for CRPS, which you and I both advocate for.
Absolutely. I think one of the best therapies for CRPS is neuromodulation.
Explain that to our viewer.
So neuromodulation is where we place some wires over the spinal cord to modulate the pain signals coming up from the affected limb. Usually, these wires are either placed over the nerve roots or what we call the spinal cord proper, the dorsal columns of the spinal cord. And the nice thing about those therapies is it can switch off some of the sympathetic supply and the pain nerves coming into the spinal cord and moving up to the brain.
It's got a bit of a bad rap lately in Australia, and that's because of many reasons, and I can give you my thoughts and views, but I believe it's political. There are a whole bunch of other factors at play. It might be because people are using the therapy that are not trained to use therapy, but essentially it works fantastically for the right patient. I did a trial of, it's called burst therapy recently on a patient, and she's had CRPS for 2 years. Couldn't work, not working, couldn't tolerate the medications because she got side effects from all the medications. We did a trial of cervical spinal cord stimulation, and Bradley, she's pain-free. She was completely pain-free, but not only pain-free, but she was sleeping. She had that pain that was gone from her face. You know that you walk in and you see a patient and you can see the pain is not there. You haven't even said hello to them, and you can see it's gone from their face.
The normal color just returns. Yeah. You know, they've lost that kind of sagginess under the eyes and the bags. They look like a different person.
Yeah. So I hope that therapy stays around for a long time. It's getting better and better all the time. Who is right for spinal cord stimulation in a chronic CRPS?
Well, look, there's a few things that you need to get right before you use this therapy. If they're a smoker, they need to quit the cigarettes. And look, there's good evidence out there that cigarettes worsen neuropathic pain.
Yes.
Besides the heart disease, the lung disease, the effects it has on your kidneys, the effect it has on, the blood vessels, there's a good cohort study that showed that nicotine consumption in nerve pain patients worsens the outcomes.
It's bad. And of course the cancer risk as well, yeah.
The other patients that are at risk are patients who are on high dose opiate therapy. Now, I'm not saying no opiates, and some of my colleagues may disagree with me and say, no, you have to get patients all off opiate therapy, but reduce down onto much lower doses of opiate therapy before you go ahead and try this. And there's good evidence to show that, when patients are taking opiates in excess of a certain amount, there's no point in trying neuromodulation therapy because you're more likely to fail.
What you need a reactive spinal cord, don't you? So you're electrically stimulating the spinal cord like the cochlear implant, like deep brain stimulation and others. So you need the nerves to react. And what do opioids do? What do all the gabapentins and Lyricas and all those medications do? They stop the nerves from reacting. So essentially it might not work.
And why get a patient into that position of, the risks of the therapy without them being in the best preclinical condition to undertake the therapy?
Yeah, and you need to be mentally well. You need to be in a good space. And that's hard for some of our patients because they've been debilitated by pain physically, emotionally as well. So sometimes you've got to bring them out of that hole that they end up in before you can do this kind of therapy, because invariably it's going to fail, isn't it?
Absolutely. If the patient is not in a psychologically stable place, you're not going to win with this therapy. And that doesn't mean that they don't have elements of depression, anxiety, all of the usual sequelae, i.e. consequences of suffering with the chronic pain. They just need to be in a stable place.
Yep, agreed. So, sorry, you were saying.
And some of my colleagues, in other places, will absolutely not give this therapy to people who have any of these conditions.
Yep.
I think that's wrong because the pain is sometimes a driver into some of these conditions as well.
And you might do a trial where you try the therapy out for longer than 2 weeks. Or you might say, and I say this to everyone I see, if they're on a little bit of opioid, remember, if this therapy works and we choose to use it moving forward, we're going to get you off your meds. This is not a add on to the medication. This is a replacement for the medication, because invariably medications cause side effects, don't they?
Yeah. And the opioids especially can cause a whole host of side effects besides the ones that people commonly know, which is the respiratory depression, i.e. stopping people breathing. It affects their mental health. And I find when patients come off opioids, they're happier.
I know, it's crazy. Actually, it's not crazy. It's just physiology, isn't it?
Absolutely. And not only that, it interferes with all of the hormones as well. And a lot of patients have got extremely low testosterone levels, which means that they're not they're not having that drive to get up and do things or engage in the therapies. And some of it's because their opioids are actually stopping them.
I saw a guy just yesterday, not CRPS, we were talking about opioids, and I said, did you know that these are the risks? And he was like, okay. And I said, did you know that testosterone is a factor? And some people on opioids for a long time, testosterone just vanishes. And he's like, I have no idea. And he had some symptoms suggestive of that. So he's off to see the GP today to get his testosterone checked, of which he should. So another risk for long-term use of opioids. We've talked about spinal cord stimulation. What are your thoughts about dorsal root ganglion stimulation? And please elaborate on what that is.
Dorsal root ganglion stimulation is where, instead of putting these leads onto, I'm going to call it the spinal cord proper, we put it onto the bits of nerves that come out, called the dorsal root ganglion.
These are the nerves that we inject and we pulse to treat the pain of CRPS, don't we?
And it's the nerves that we apply the pulse radiofrequency to as well. And the wire then sits over these nerve roots and stimulates the nerve root directly. It's got some nice advantages. It can treat focal pain really well. So if you've got pain of a particular part of the body, the knee, the foot, you can place these wires around that focal pain area and get a very good response to the neuropathic pain. It does come with some issues though, and that is,
do tell.
It's a bit of a fiddly therapy. The wires have a slightly higher risk of fracture, of displacement than putting the lead straight onto the spinal cord proper.
One of the things I do like about the therapy is that the battery is what we call a non-rechargeable battery. So patients don't have to recharge the battery, which can end up being a burden at times. And some of the issues that patients have with spinal cord stimulators or nerve stimulators is the charging. So DRG, you don't need to do the charging because the therapy current is so low because it's right on the nerve, so you don't have to have a lot of current, so the battery lasts for a very long time. But you're right, it can be a bit fiddly to put in, but if you can get it working, like anything, for the right person, for the right pain, it can be life-changing.
And look, you're absolutely spot on, Nick. Because you're using such low energies, there's less risk of what we call habituation of the therapy with dorsal root ganglion stimulation. When it's effective, it's ongoing effectiveness. The other downside is sometimes in CRPS it can spread, and then you may have to go and do another nerve root, but it's something that can be overcome with therapy.
So if spinal cord stimulation, dorsal root ganglion stimulation are not affected, but we've talked about SCS and DRG stimulation. So that's where we believe pain is generated and driven at the spinal cord level, and hence that's where the treatment is. Incidentally, that's where medications work as well. So you take them orally, but they get to the spinal cord, which is where they have their effects. Is there any merit in doing peripheral nerve stimulation? And please elaborate on this.
I think there is merit in doing peripheral nerve stimulation when it's a single nerve fiber that's been affected and is generating some of this CRPS.
Okay.
I've used peripheral nerve stimulation in some neuropathic pains and had very good results, and it's got some nice properties to peripheral nerve stimulation. It's low risk. You're not going near the spinal cord itself, and you're treating a very focal pain with the tiny little wire that you're putting around the nerve.
So, for example, if you've got the median nerve that's been affected by a surgery, carpal tunnel, you've got CRPS of the hand, it's just a single nerve. And so this is a little flexible wire that we can put in essentially through an injection with no battery. And the battery is externalized on a little sticky plaster that you just put over the wire when you want to use it. And we'll put some pictures up for the audience. Would you have one of those yourself?
Oh, absolutely. If I had that focal pain, the risks from putting this little wire in, I think, are very minimal.
Yeah.
And the potential benefits that I've seen from patients is phenomenal.
Yeah.
I've had patients where they've had intractable pain in their foot and ankle.
Yeah.
We've managed to figure out that one of the nerves are responsible, put a wire down, and they're off their meds, they're back at work, they're engaging in life, they're doing all the activities, walking, running again, and doing a lot better.
Take a step back. Would you advocate for the use of spinal cord stimulation in yourself or one of your dear family members?
Yes, I would. The risks of spinal cord stimulation are absolutely there, and we can't take that away.
Sure.
However, the risks are low when you compare it to the other forms of treatments that we do in medicine.
Yeah.
The benefits I see from spinal cord stimulation is long-term, ongoing pain relief without medication.
And the patients with CRPS get better over time. So it's not something that's going to be as good as it gets over 3 months. It's going to be better in 6 months, even better in 12 months, even better in 2 years. I've had many people where they get better over time. It's almost like recovering from a stroke or something. You have a stroke, you've got to learn to feed yourself and walk and do everything again. And that doesn't take weeks and months. That takes months and years. And the same thing applies when you're stimulating that part of the nervous system. It takes time for it to unravel, get back to a normal function.
But these devices need to be put in by the right trained person, because they're not a simple set and forget device. It's not like a pacemaker. You put it in, it's done. They sometimes need a little bit of tweaking and programming. So you need somebody who's familiar with doing these therapies, who's there for the ongoing management of the device as well.
So same thing to our audience members. If you're going to use these advanced therapies, make sure you ask them if they're appropriately trained, if they're going to manage you for the long term, if they're not going to just stick it in and send you on your way and say, I'm done. Because even if you've got one of these therapies, you still need to manage the medication, still need to get fit and strong, you still need to deal with your mental health and whatever else happens along the way. I've got a lady who had a nerve stimulator and she developed cancer. And so we had to help her through the cancer therapy and the surgery, and it's a long-term process, isn't it? Chronic pain,
unfortunately so, and things can change.
Yes,
and so sometimes where you place the wires, you may need to go and revise them because the pain has changed, and you need to cover a slightly different area.
Yeah,
and so it does need ongoing treatment, but. Like you, I've had patients with CRPS. They've been treated with neuromodulation therapy and their pain is gone. They're pain-free. And they've come back to me a couple of years later and said, Brad, I'm not using it anymore.
So did you just take it out?
Not first of all. I make sure that, the pain is really gone. So I want them to go away, have it off for a year or two. But the nice thing about it, this is a reversible therapy. It can all come out.
Okay. You forgot to tell something to our audience.
Oh, I did indeed. So I just want to make it clear that these podcasts are for educational purposes only. They're not medical advice. If you have any of these ongoing conditions, speak to your GP, see a trained professional. This is just a candid conversation between Nick and myself to give you information about therapies that are available out there.
And I would add to that, if you are in Australia, in Melbourne, in Victoria, or even Australia-wide, and you're suffering and struggling with chronic pain and you're not sure what to do, we'll stick in some links below. We're here. We're very good at what we do. And I would advocate for that. Our clinic is made to be good enough for our families, isn't it?
Absolutely.
And I can share with you, I have family members that are treated by yourself and some of the other doctors as well, because I thoroughly trust everyone in this clinic. So reach out. And even if you're international, we do have telehealth consultations, and I've seen people from the USA and other parts of the world as well. We're here. We're good at what we do. The other thing is that for those watching, if you are here with us now, please like and subscribe. It changes the algorithm and it gets this message out there, because we've just got to get this message out there. Let's stick with advanced pain therapies. What other advanced pain therapies can you consider for chronic severe CRPS?
The one therapy that I think is a bit underutilized in general is intrathecal drug delivery devices.
Bradley, please tell us what that is.
So that's where we place a tiny little flexible plastic catheter over the spinal cord where the area of the pain we believe is coming from. And this little plastic catheter then releases a drug. So instead of spinal cord stimulation, where we use electricity to turn it off, we revert back to using medications. However, the medications that we use are similar to the medications that would give you orally, like morphine. But we can use these in tiny, tiny little doses because we're right next to the nerve fibers. And because we're delivering it to the nerve fibers that are responsible for where the pain areas in the patient, it doesn't go up into the brain usually, and it doesn't cause all of the side effects that we get from using oral opioids, which we have to use at doses 1,000 to 10,000 times bigger than what we use in these pumps. The pumps themselves are small little devices that need to be placed underneath the skin to continually deliver this medication, and they come with downsides of needing to be topped up regularly and also managed. But with these therapies, we can get patients off all of the oral medications. And the nice thing with that is that they're no longer interfering with the brain function, i.e. patients are feeling brighter. They're not suffering all of the side effects from the opioids with the bowel dysfunction, with the hormone dysfunction, because you're using these tiny little doses.
Again, very underutilized therapy, and certainly for CRPS that is refractory, morphine is an option. Sometimes baclofen is used as well, which can help with the dystonia and the contraction. So baclofen's for spasticity. The multiple sclerosis population use intrathecal baclofen for severe spasticity, and it's game-changing for that patient cohort. In America, they use aconitide as well, which I don't I'm not familiar with for neuropathic pain. We don't have access to that in Australia. Do you know much about it?
It just what the NACC consensus guidelines says. It's part of their first line approach, and it's a local anesthetic agent that can only be delivered into the spinal cord space. You can't use it anywhere else in the body.
Okay.
But unfortunately, we don't have TGA approval for ziconotide, and there's not many places where you can get it in Australia.
No, and just talking about intrathecal therapy, I think we're one of the few or handful of places around the country that would use intrathecal therapy for severe refractory chronic pain. We do use it for cancer pain as well, and that's another population where it can be, I'm trying to use my words carefully here, it can basically just change quality of life for people suffering with cancer. I had a lady who had severe cancer pain, and she couldn't go home because she was on all these medications and she kept falling asleep. So we put a pump into her and she got off all the oral medications, close to pain-free, and she died at home and she died with her family at her side, and it was the way it should be. So intrathecal therapy. Okay, we've promised our viewers that we were going to discuss a little bit more of a controversial therapy, and so I'd like to bring up amputation now. You and I are very experienced. We've got more than 20 years of experience each in terms of pain management, and of course that comes from the anesthetic background, and I can tell you stories about people that I've seen have amputations for CRPS. I suppose firstly, this is not usual therapy. There are some risks involved, but I wanted to bring it up now because it is a bit of an elephant in the room. A lot of people would ask for amputation. I got patients that go, "Can you just chop it off, please?" And they say it in a slightly flippant way, but I know there's an element of, actually, I just can't deal with my limb anymore. I'd like viewers to give us your thoughts and comments down below as well. Where are you at with amputation, Bradley?
Well, look, amputation used to, as far as my training was, an absolute no-no in CRPS. And like you, Nick, we've seen from our anesthetic training, a lot of amputation patients come through and then they end up in the chronic pain clinic as a result of their amputation. And like you said, it's not risk-free. You're losing a limb. It's affecting you psychologically. You're no longer the same person you are. In some patients, it can improve their mobility because actually they can use prosthesis to help them mobilize around. But the big risk, I think, is actually from it worsening your pain. And we know after amputation, there's a huge number of patients, between 80 to 90% will have phantom limb pain.
So phantom limb pain is a possibility.
And there's phantom limb sensations as well that come about after an amputation, where people still feel the limb and that it's moving around. However, those are not painful sensations. And then there's always a risk of CRPS after amputation. So you could go and amputate a limb, and then you could end up with further CRPS moving up that limb as a result of the amputation as well.
I agree. I always thought amputation was essentially a no-no, but preparing for this podcast, we did some reading, you and I, and there is a paper which I'll share with the viewer. The paper that I'm talking about was published just last month in 2025, and I thought it was pretty interesting because essentially what they said was they had 39 patients that had median of 12 years of CRPS, and a significant amount went on to have an amputation. So the quality of life disability scores improved. 94% was satisfied with their decision. However, 77% had residual limb pain, 85% had phantom limb pain, and 10% had CRPS recurrence in the stump of the limb amputated. So essentially, I've always thought it's just a no-no, but there are a group of people that appear to have gained some benefit, but as long as you're aware of the risks. That was one paper. There was another paper looking at 47 patients, and similarly they showed about a 70%, 75% improvement in mobility and quality of life and reduction in pain, but the CRPS returned in about 10% of people, so 10% seems to be a common number. And another paper looked at studies, and they showed 60 to 70% showed improvements, but the phantom limb complications, phantom limb pain, occurred in a high group, 65%, stump pain in 45%, and CRPS recurrence in 30%. So I have to say, if a patient asked me tomorrow if their CRPS could be treated with an amputation, I would probably pause, take a breath before I just said no. And I would say it's not ideal. It's certainly not usual therapy. There are many risks involved. These are the risks. And if we're ever going to embark on this seriously, I would want external specialists involved as well. I don't want to just have us within the clinic involved. It would have to be the GPs involved, possibly a neurologist or some external medical physician. Would you get a psychiatrist involved, Bradley?
Absolutely, you need a psychiatrist involved, because if you're going down this pathway, you need to make sure that patients in a psychologically stable condition, they could go down and have this treatment done and find that because of the loss of body image, loss of self-worth, their mental health could dip down so severe that they could be at risk to themselves. And you need a psychologist involved beforehand and afterwards, because we know that post-amputation patients suffer with issues such as body dysmorphia, loss of self-worth, loss of sexual function, and they'll need a lot of support around
massive.
them.
It's absolutely massive. You forget an amputation has its own inherent problems as well. And of course, what if the prosthesis doesn't fit? Or what if it doesn't work very well? Or what if it makes the pain worse? We treat phantom pain as well. Obviously, in this clinic, we treat all types of chronic pain. And phantom pain can be really hard to manage, Any heartfelt stories, any heartfelt things you want to share with our audience? I'm mindful of time, but again, I want to make sure that everyone gets what they've come to this podcast for.
Well, look, obviously these papers that we've picked up now have changed the way I look at amputation and chronic pain. And for some patients who have that limb that's no longer functional anymore, and Nick, you can probably attest to this, there's CRPS and then there's severe CRPS, where a limb can become contorted in the way that it appears, it doesn't move, it limits the patient's ability to put on clothes or put on a shoe anymore because it's so disfigured from the CRPS. I might think differently about these types of patients moving forward.
Yeah, I've got a patient who I've known for quite a number of years. She's under the workers' comp system. She's got a spinal cord stimulator in for Hand CRPS. The pain is well controlled to a point, but the hand is just not doing anything. It's clawed. It's useless. And again, she's never brought it up herself. But I wonder if I talk to her next, would it be something that morally, ethically, you should bring up? I don't know. I've just thought about that.
It's difficult because amputations as part of medicine is something that it's
just a no-no.
We just hate doing.
Yeah.
We want to be the big heroes all the time and get there and improve people's quality of life. And I think what this paper does force us to realize is that sometimes in a very small selection of some of these patients, their quality of life may be improved by that.
And that's what we're about, whatever it takes, as I say, whatever it takes to improve the quality of life, providing it's ethically appropriate, morally appropriate. Even opioids to some, for some people, it's okay to have opioids, providing the dose is low and there are pros and cons and, testosterone levels are checked and all the other things.
And they're monitored in the right supportive environment with the right team around them. And that's the key, is getting the patient into the right therapy at the right time with the right support.
Yeah. So we're gonna start wrapping it up. We've got lots that we can talk about. Please subscribe, because you will get more on CRPS coming up. And you and I are now talking about trigeminal neuralgia, which is a massive topic as well. So we'll start putting together the next one. Before we wrap it up, I just wanted to ask you for any closing thoughts, closing comments on the interventional approach for acute, the interventional approach for chronic CRPS.
From my opinion, the interventions that we can offer are all part of a package of care that we need to set up for a patient, done with a very experienced pain physician to build an individual pain plan for a patient. It comes with education, with getting the patient into the right physical support and right mental health support. And I think if you manage to bridge all of these different areas, absolutely there's things that we can do to help patients move forward with some of their control of their pain.
Good. I would concur with that. And the bottom line is, if you're suffering and struggling and you're not moving forward anywhere, don't be despondent. There's always something that can be considered. And that's what you always say, isn't it? There is never nothing that can be considered. You can always get somebody in, do a ketamine infusion, tidy up the meds, flip the meds, change the meds. I saw a guy today I haven't seen him for 8 years because he got disrupted during COVID, and he just hasn't come back. I think it's 5 or 6 years now. And we're basically starting from scratch again. We're getting him his allied health team. We're getting his medications tweaked. He needs to see a psychiatrist, which I need to sort out. And sometimes you just got to start again.
Absolutely correct, Nick. You get patients, they do very well, and sometimes some stuff will happen and things have changed. So it's this relationship that you form with patients, I think, with suffering from this condition, unfortunately. I said, I'm just lucky this profession was available. I don't think I'd make it out there in the real world.
As an actor?
No, definitely not.
No. Stick with what you're doing. You're doing it well. Patients love you.